Good morning, everybody. I'd like to start by thanking the Davis Phinney Foundation for inviting me to present for you guys today. This is truly an honor. And what I was asked to present on was an update on research. And so that's a little bit of a challenge in a 30-minute time frame, but we'll try to give you an idea of some of the topics that are out there that hopefully you will see coming to a pharmacy near you. The first thing I wanted to do was maybe give you a little bit of an introduction to research and what exactly that entails. So let's start with the definition of clinical research. So clinical research itself is either directly involves a particular person or group of people and uses materials from humans such as their behavior or samples of their tissue that can be linked back to them so that we can define what's going on with disease. And of course, this process protects personal data. So there's several different types of clinical research. Most of us here are familiar with a clinical trial, and I just want to emphasize that a clinical trial is only one type of clinical research. And amongst the subcategory of clinical trials, we can have either interventional trials or we can have observational studies. So interventional trials are those in which an investigator will give a treatment, some kind of a drug or perhaps an intervention, and then measure the effects on an individual or on a disease process. In observational studies, there really is no intervention at all. It's purely just examining how symptoms progress or what kind of changes are present. And things like measurements of brain activity, genetics, or environmental factors, these are the things that might fall under the category of an observational study. And these are usually done to try to better understand a disease and ultimately will lead and guide future treatments, therapies, or interventions. So that's clinical research. We also can talk about basic research. So basic research is the systematic study that's directed toward a fuller knowledge or understanding of fundamental aspects of phenomena. And so really this is more of a quest for new knowledge. You can think of it as exploring the unknown, research in which we're trying to understand more about what's going on, but not necessarily with a particular therapy in mind or a particular process. You're kind of keeping an open mind about what might happen, although you might have a particular hypothesis about how that might turn out. So this is conventionally referred to as either bench research or laboratory research. So amongst all of this clinical and basic research that's going on, and there's plenty of it going on in Parkinson's disease, and we'll try to touch on some of these aspects of it, there are several challenges to how research about Parkinson's disease occurs. So some of this is related to the fact that we still have limited knowledge and understanding about the molecular underpinnings of some of the motor symptoms. And so for things like dyskinesias or gait freezing or postural instability, we know that they happen. We have a fair idea of when to suspect these problems, but really understanding how they occur and then how to target specific therapies for those symptoms is still an area of investigation. Similarly, we have limited knowledge about the specific treatments and mechanisms that are relevant to non-motor symptoms, and these are all the things that happen in Parkinson's that aren't necessarily related to physical movement. We still need better animal models in order to understand this disease process. The ones that we have are good, but they may not be exact ways of replicating human disease. And so enhancing those models will also help us to study treatments better and to study the disease better. And we're increasingly recognizing the role of non-dopamine mechanisms. Everybody's familiar with the dopamine loss and what not having enough dopamine in your brain can do. But really there are other chemicals in the brain that we might be able to target that can influence how Parkinson's progresses or how the symptoms manifest themselves. Another thing that we have to keep in mind as researchers approaching this disease is that there are probably several different ways that people can develop Parkinson's. It's probably a group of disorders that then results in a final symptom complex that we can call Parkinson's disease, but there might be different paths that people have to, or that may occur that lead to the ultimate presentation of that symptom. And so then when we're thinking about how that might apply to treatments that we are looking to develop that are based on these different mechanisms, we have to realize that there might be a group of patients that respond better to that therapy and other groups of patients who won't because there's different mechanisms at play. And kind of the last sort of big challenge that we have to research in Parkinson's is that the natural history of Parkinson's is long. People are going to live a decade or more with this condition, and it's really hard to just start a treatment and wait 10 years to see how exactly things pan out. And of course, the longer we try to conduct trials, the more expensive that becomes as well. And so these are all the different challenges that we have to try to work around and figure out exactly how best to enhance the process and bring true treatments that are really helpful for our patients out for general use. So what we're going to talk about then now is 5 top areas of research that I think represent really some of the most exciting stuff that's going on now, and hopefully some of the more tangible things that we might be seeing. Before we talk specifically about biomarkers, I do want to highlight a little bit about the natural progression of Parkinson's. And this may look like kind of a complicated slide, and I apologize, I don't have a pointer to really show you. But if you look at that dotted blue line there at the bottom, that represents the motor symptoms of Parkinson's disease. And you'll see that if you follow that dotted blue line, that things are people really don't have symptoms until a certain point. There, on that orange line, that first one is the threshold for development of some non-motor features of Parkinson's. So even before a patient develops tremor or stiffness or changes in walking and balance, there might be some subtle things like sleep problems, dream reenactment, mood issues, constipation, other symptoms that we refer to as these non-motor symptoms that precede the onset of the actual tremor. And it's usually not until people develop that tremor or other specific movement problems that they'll come into my office seeking a diagnosis. So there's a gap there in terms of which symptoms start and when those patients get diagnosed. And even if they come in at the time that they are experiencing symptoms, usually it's been a few months or even a year or two sometimes in different cases before that actual diagnosis gets made and then treatment can be initiated. If you look at that yellow line on the top of this graph, that actually represents the progression of dopamine cell loss in the brain. And you can see that even in very, very early preclinical stages, there's probably already a process that's beginning that's starting this loss of neurons. And then you see closer to those pre-symptomatic and symptomatic lines that dopamine cell loss really progresses. But by the time somebody comes into my office seeking a diagnosis for Parkinson's symptoms, they've already lost 60 or 70% of those brain cells. So clearly, something has already started happening, and if we wait until after that to start initiating treatments, it's going to be that much harder to find or to administer some kind of disease modification because that process has already been going on for so long. So really, the idea is that we have to be able to find out earlier which patients are going to be developing symptoms of this disease in order to be able to really develop those neuroprotective therapies or treatments that are going to slow the progression. Keeping that in mind, you've got this long disease process. And I've already mentioned to you that with this natural history, trying to conduct clinical trials is all the more challenging. Clinical trials are difficult anyway because recruitment can be slow, retention is difficult, especially the longer that a trial goes on, and that's partly due to patient inconvenience, meaning they have to spend time traveling, an expense to kind of come back and forth for the repeated assessments, and from a sponsor standpoint, there has to be a great deal of effort spent on standardizing operations for these multiple clinical sites that are performing the actual procedures. So that just builds up in terms of how much money has to be spent and how much time has to be taken in order to do this. And the picture that's on this slide here just sort of represents from a few years ago the fact that it can take upwards of 15 years to bring a drug to market and hundreds of millions of dollars. So one big question that we all have is, can we change the rate at which these new therapies are developed? And on this slide, you'll see kind of a pictorial representation of that whole process. And really what I wanted to highlight there with those arrows is that you may take several steps forwards in this process, and there might be steps backward that you have to take as well. And so really, what is the best way that we can streamline this in order to shorten that time that we can bring these actual new treatments to patients who ultimately are the ones that are going to benefit from the disease? So with that in mind, there is an initiative going on actively as we speak called the Parkinsons Progression Markers Initiative, and many of you may have heard of this or might even be participating in it. And this is a study that's being sponsored by the Michael J. Fox Foundation, but also with the support of several different pharmaceutical and biotechnology companies. And it's aiming to study 400 Parkinson's patients, 200 unaffected controls, healthy volunteers. They're looking to follow these patients for 3 to 5 years in an observational study. And the goal is that we're going to perform a series of assessments on these patients on an annual basis. So initially, I think it's baseline 6 months, 1 year, and then 2 years, 3 years, et cetera, until the course of the study is complete. And it's looking at various clinical assessments of symptom severity, cognitive issues. It's looking at imaging assessments, measuring brain function and MRI structural changes in the brain, and also biological sampling, including blood, spinal fluid, urine, and DNA analysis. And the ultimate goal of studying this many people dedicated for over a period of time with repeated analyses is to try to find a chemical or biological signal for Parkinson's that can then ultimately be used as a biomarker. So what is the role of a biomarker, and why is this so important? There's several different ways that a biomarker can actually be helpful in Parkinson's, but I'd like to draw your attention to maybe a few things. This is sort of a busy slide that you see here, but screening biomarkers can certainly help us identify people at risk for Parkinson's earlier, so we really can get them started on those disease-modifying therapies. Diagnostic biomarkers can help us ensure that we're enrolling the right people in clinical trials so that when we get the results of those studies, we'll be able to generalize them a little bit better to the population at large. Staging biomarkers might help us really identify subtle changes that you can identify biochemically, but you're not necessarily going to see physically with a patient if you're just assessing things like hand movements and tremor and stiffness. And so that, of course, can speed up the clinical trials process and maybe even help us inform or adjust the way that we're designing these clinical trials. So there's a lot of good reasons that or a lot of very strong reasons that we need biomarkers, and this is, I think, just a very important thing that has finally gotten off the ground, and hopefully we're going to find some very exciting information in the near future. It's already a couple of years underway. So other things that I thought were important areas to discuss were non-dopamine mechanisms and motor symptoms. So again, we talk, and everybody's familiar with dopamine and how that affects movement, but there's really other chemical pathways that can be targeted in Parkinson's. And one of these is the A2A receptor, and treatments that might be A2A receptor antagonists. So what is that? A2A is responsible, its activity is responsible in the brain for releasing an inhibitory chemical called GABA. And if you block these A2A receptors, then the amount of GABA in the brain in the pathways responsible for Parkinson's would increase, and it actually could potentially attenuate or reduce Parkinson's symptoms. So it's a way of modulating the dopamine system by using a different chemical, and maybe by doing that, we won't have the same issues and complications that we currently have with our current treatments. So in animal studies, one of the drugs that was developed is something called Ethylene. And again, some of you may have heard of this, you may have even participated in the trials, but it was found to improve movement function without worsening dyskinesias. And so that might mean for a patient with Parkinson's that they could add a medication like this and be able to reduce the amount of levodopa they're taking. Also in animal studies, this drug showed that it actually prevented dyskinesias. So for patients, what that might mean is that if you started a medication like Ethylene early, it might prevent the development of the levodopa-induced dyskinesias. So Ethylene was the first one of these drugs to be developed and brought out to clinical trials, and unfortunately the initial studies were not statistically significant, so they didn't show an obvious difference between treatment and placebo groups. So they're going back and redesigning those studies and are actually going to be coming out in the near future with a redesigned study that will hopefully try to address the issues and hopefully be more successful. But there are 3 other agents that have been in development with a similar mechanism of action, and I think this is a very exciting research and an exciting opportunity to pursue for Parkinson's treatment, simply because it's a way of dealing with symptoms that doesn't really involve dopamine. So hopefully we're going to find out some more positive information on that in the future. Another non-dopamine mechanism is this glutamate receptor antagonists. So Dyskinesias in Parkinson's are typically associated with having too much glutamate activity in the brain. And those of you who may have taken amantadine for treatment of your dyskinesias, this is sort of the same type of pathway that we're talking about. And we know that certain glutamate receptors are increased in the brains of animals that have been made Parkinsonian. And we know that blocking those glutamate receptors actually can reduce the dyskinesias. So a couple of companies now, Novartis and then another company called Addex, have developed drugs that work on this mechanism. And they've shown to either reduce dyskinesias or in animal models also maybe even affect dystonia. So again, we're looking at different ways of tackling the problems in Parkinson's disease by medications or treatment routes that don't necessarily directly involve dopamine. Another non-dopamine treatment for Parkinson's, of course, is deep brain stimulation. And so a lot of you may either be directly familiar with it or have heard about it. And I certainly get a lot of questions about this, sometimes even from the very beginning when people come into my office with needing their initial diagnosis. And so often the question is, when does deep brain stimulation when do we typically consider it? And the conversation I have with my patients is usually, as time goes on, we're going to have to adjust your medications. It may end up that you're on 4 or 5 different medications to treat Parkinson's. And this is all aimed at trying to get your optimal function. But if we've tried all of these different things and you're still having problems with fluctuations, meaning the medications are kicking in and wearing off, or you're having dyskinesias, meaning the involuntary excessive movements, and maybe those medication effects are very unpredictable, this is usually the time that we start entertaining the possibility of deep brain stimulation. The only other potential or specific situation that we would typically consider deep brain stimulation if somebody had a lot of tremor that really just wasn't getting better enough with all these different medications combinations. So the idea behind deep brain stimulation is that there's a time where it's typically considered. And if you look at that bottom part of the slide up there, it sort of shows the disease progression in terms of severity. And when you have mild disease, we think that, or we can typically control symptoms pretty well with medications. But when you get into the moderate stages of disease, where you start having those wearing off and those fluctuations, that's when DBS might potentially start having a role. When you get into those severe stages of Parkinson's and there are medication refractory symptoms, things like postural instability, freezing, or dementia, this is a time frame where the effects of DBS are typically, you're unlikely to have effects of DBS as well. So there's this idea of a window, and the whole kind of concept of DBS is finding when that window starts with the patient and getting there before the window closes. And so along with that, we kind of have conversations about what we reasonably would expect from deep brain stimulation. And you guys are going to get, I think, a more dedicated presentation on this later, so I don't want to necessarily spend a whole lot of time. But we're looking to help dyskinesias, help fluctuations, help tremor and other Parkinson's symptoms. But we also have to keep in mind that DBS is not necessarily preventing disease progression. And we know that certain symptoms in Parkinson's are going to progress despite the fact that there's a stimulator and despite the fact that we can adjust the stimulator. So there's been, I'm going to skip over this slide. Can I go ahead and have the next one? There's been some interest in looking at the effects of deep brain stimulation when used earlier in the disease phase. So rather than waiting until those moderate stages, maybe trying introducing DBS earlier on. And so this is some information that is starting to come out now from our colleagues in Europe. And they conducted a trial in which patients who had relatively recent onset of these motor complications, fluctuations, dyskinesias, but who were still occupationally and socially functioning very well, and performed deep brain stimulation on those patients and did some rating scales and videos and had blinded raters looking at the outcomes of the motor function in those patients. I want to draw your attention to the fact that previous studies, if you look at that table there, previous studies of Parkinson's dating back to 2006, we were operating on patients who were in their 60s on average and who on average had a disease duration of about 13 years. And in this study, we're down into our 50s in terms of when they were actually operating on the patients, and these patients had probably only about 7 years of disease duration. So definitely a younger population earlier in the disease course. And they followed these patients for 2 years and found that their motor functions were better, their activities of living were better, the presence of the fluctuations in the dyskinesias was better compared to those patients who continued to undergo medication treatment. And so what does this tell us? Well, I think this is probably not unexpected. We know that deep brain stimulation helps Parkinson's symptoms. So far, that's certainly what we're seeing in this trial. But I think the bigger question about what deep brain stimulation does for patients if we treat it earlier with DBS is going to come out in the long term. And we have to see if there's anything that comes out favorable for early stimulation, 5, 10, 15 years down the line, as opposed to the traditional treatment, which would be at that time frame as well. So I think we need more information. The information that's coming out is still very early, and hopefully with time we'll get the information on exactly how helpful earlier surgery is. So then we can move on to non-motor symptoms. Again, I think you guys are getting a dedicated presentation, so I'll just sort of briefly present this. There are a variety of non-motor symptoms in Parkinson's, and they're getting increasing attention because we're now understanding very well how much these problems can impact a person's quality of life. And this runs the whole gamut from mood and memory to other bodily functions like bladder and bowel control, blood pressure, etc. If somebody comes into my office complaining about these issues, I have many different treatments that I can offer them. But part of the issues are that there's very little direct evidence about how well these treatments work in Parkinson's patients. And there's few clinical trials that are really dedicated to studying a particular non-motor symptom in Parkinson's patients. And we really need to, and I think there is increasing interest in this, and we're going to see a lot more of this type of study coming out in the future. But I wanted to give you a couple of sort of exciting possibilities that are probably going to be coming to a pharmacy near you in the future. The first is pimavanserin. And pimavanserin was a medication that was developed for treating hallucinations and psychosis in Parkinson's. And traditionally, we have to use antipsychotic medicines, which, of course, kind of do the opposite of what we want in Parkinson's. They block dopamine. And you certainly don't want to do that in somebody who already has less dopamine. And there's other side effects that are associated with those medications, and we're really restricted to using 2 of them that don't seem to be as problematic for worsening Parkinson's symptoms. So pimavanserin is a medicine that works on these hallucinations and other symptoms of psychosis by modulating serotonin. It's actually a serotonin receptor blocker. And so you really don't get that degree of worsening Parkinsonism that we're worried about with the other antipsychotic medicines. And their clinical trial was positive, and their FDA submission is in progress. So hopefully this will be coming available to us. And it will be specifically for treating hallucinations in patients with Parkinson's disease. Another medication that was studied specifically for problems that Parkinson's patients have is a medicine called droxidopa for treatment of orthostatic hypotension. And orthostatic hypotension is that drop in blood pressure that happens after you stand up. And this problem is exaggerated in a lot of patients with Parkinson's. So current medicines that we use to treat this problem cause risk of high blood pressure, so they may actually overshoot, and some of them may cause problems with volume overload, and so we have limited options. Not everybody responds to those medicines or even tolerates them. So droxidopa was studied specifically in a Parkinsonian population and was found to increase blood pressure without causing an overshoot into hypertension. And again, it was looked at specifically in Parkinson's patients and was found to be safe and should be coming to market soon as well. So those are a couple of Parkinson-specific treatments for the non-motor aspects of this condition that we're going to see coming out. And there's, of course, a lot more research going on in this area as well. So the next area was about disease progression. And I'll just start out by saying that the things that we know about Parkinson's today, although our knowledge is expanding, still represents kind of a tip of the iceberg. And there's a lot of basic sciences research still going on now, trying to identify all the underlying mechanisms that are contributing to the loss of those dopamine neurons and changes in other parts of the brain. And it's really through knowledge of those things that we're going to be able to find adequate treatments that are clearly established to slow the progression of the disease. So basic sciences research in this area is very important. There are some studies that are underway of medications currently looking to do exactly this, to slow the progression. And one of these is isradipine, and it's actually a blood pressure medicine. And it's been around for a while. The FDA has approved it, and people in the past used to use it quite a bit for management of high blood pressure. And studies have shown that isradipine is a calcium channel blocker. That is how it actually lowers blood pressure. And we know that dopamine neurons also use calcium channels, but the problem is that the calcium channels that they use can actually aggravate the cell and cause or contribute to some of the stress that cell will experience and perhaps contribute to the cell loss. So isradipine will go in, and it's been shown in animal studies, to block the calcium channels and block a certain type of calcium channel and allow that neuron to use a different type of calcium channel that's less toxic to the neuron. So it's potentially a way to help slow the cell death. And there's other evidence that suggests that patients who take calcium channel blockers have a lower incidence of Parkinson's disease. And so now there are studies that are going on to look at whether this is actually a viable way to try to slow the progression of Parkinson's disease. And these trials are currently underway. Another treatment that's being investigated is inosine. And to talk about inosine, you have to understand a little bit about uric acid. Uric acid is something that urate levels can be measured in the blood, and it's been associated with Parkinson's because patients who have a higher baseline urate level have a delay actually in the need for dopamine treatment. And higher urate levels are actually correlated with a lower risk for developing Parkinson's disease. So this is very relevant. Inosine is a medication that can actually be given to increase urate levels. So maybe there's a way in patients with Parkinson's who have lower urate levels, give the inosine and see if it can help progression. And the reason is because urate is an antioxidant. It's also a free radical scavenger, and this means that it may have an impact, again, on that cell death and neurodegeneration. So treatment with inosine is currently being studied as well as a way to slow disease progression. Another one that I think is very interesting is a diabetes medication called Pioglitazone. And some of you may say, well, why on earth would you use a diabetes medication in Parkinson's? And this is the reason why. Pioglitazone, in addition to its effects on blood sugar, actually is also known to be an antioxidant. It's also an anti-inflammatory medication, and it tends to increase expression of a protein that's important for mitochondrial function. And mitochondria are the energy powerhouses of the cell, and they're very important for function of these dopamine neurons. And so studies are looking at whether the use of pioglitazone can actually slow cell death and slow the progression of Parkinson's disease. Exercise, of course, is a big focus of the Phinney Foundation. And I don't want to go through this in detail because I think that's going to be a recurring theme, but there's a lot of animal evidence that suggests the good benefits of exercise, and also a lot of clinical trials experienced to date that shows that exercise improves physical function, improves quality of life, strength, balance, gait, and even measurement of Parkinson's symptoms. So we can actually measure differences in symptom severity in patients who do exercise versus those who don't. And there's several examples of different therapy exercise programs. It doesn't have to be a specific type of exercise, but again, like I said, you guys are going to hear more about that throughout the day today. So I just want to conclude with a few comments. Parkinson's is, of course, a very complex disorder, and I hope what I've shown you is, even though it's not very well understood, there's a lot of very good research going on right now that is aiming to, A, understand disease mechanisms better, but then also to translate that understanding into treatments that are going to treat the disease, and also open up avenues to develop new possible treatments for symptoms. And even though most of the current treatments that we have are focused on motor features, there's a lot of research going on that is looking at the non-motor aspects of this condition that we know that are affecting people on a daily basis and affecting their quality of life. And we know that this research is going to continue and that the need for biomarkers is there, and we've now got a big project underway looking specifically for that so we can bring these to market. And I just want to encourage you guys on my very last slide here to try to engage. None of this is going to happen without patient participation, and we definitely understand your role in this. And so as much as you can get involved, we want to encourage you to do so. And there's several ways to do that. Pharmaceutical companies and other research groups are looking for patient input, and there's ways to get involved in that. You can certainly become involved in a clinical trial, advocate for participation in clinical trials, advocate for research, et cetera. And as much as you guys can do in the grassroots, that's only going to enhance the process and get us what everybody wants, which is a better way to treat Parkinson's disease. And with that, I will stop. Thank you for your attention.